Awesome. Thank you so much for the invitation. It's a great pleasure to be here. And congratulations for this wonderful symposium. Today, I'm going to talk about brain health from the lens of aging brain. And definitely, we're going to talk about cerebrovascular care in terms of the preventive role for preserving brain health through aging. I don't have any relevant disclosures. These are my research funding acknowledgements. So first, we're going to talk about what is aging and what does it mean for brain and brain aging. What are the brain health trajectories through the aging process? And then we're going to talk about the strategies that we can apply to preserve brain health and see whether we need to take reactive or proactive approach. And hopefully, and then we're going to have a great discussion about where should we go from here. So I would like to start with this very telling figure that shows that we are really going through a longevity revolution. In 50s and 70s, globally, less than 5% of the population in the world belong to the age group of 65 and more. And this number currently has reached to about 9%. It's projected to become like 20 to 25% in 2100. But this is a global number, and of course, already in certain regions in the world and in the US, we are already there. A place like Vermont, more than 25%, near 25% of the population belongs to that age group, which really tells us about this rapid aging in our populations. So when we have this such a rapid aging and longevity revolution, it is hard to not think about what would be the consequences for neurological disorders and what would be facing when we have an increasing number of individuals that belong to that age group. This is a study that was published by a group in Rotterdam in the Netherlands. And for thousands and thousands of individuals, they followed them over the decades to see what would be the lifetime risk of a neurological condition. As you can see here, about age of 65, only about 5% was lifetime risk, and it really jumped to 6 times higher by the age of 85. And then they did a very interesting analysis. And what did they do was that they showed that if you would be able to delay the onset of neurological conditions, like for 1 to 3 years, you don't have to eradicate them or anything like that, just push them 1 to 3 years, you can reduce the burden by 20 to 50%, which has huge financial and healthcare system implications. So we frequently talk about some concepts, including aging, and brain health and disease. And I'm hoping that we can review that first before getting further. So when we think and talk about aging in simple biological terms, basically aging is accumulation of the damage in the absence or failure of healing mechanisms. And when we talk about brain aging is basically a constellation of morphological and physiological alterations in the brain that is because of the accumulated damage that ultimately leads to impairment in motor, sensory, cognitive, and social skills. As we can appreciate, that has happened in some prominent figures. But what does it mean when we talk about brain health versus brain disease? I think the concept is really evolving. There is so much talk about brain health, and it's not a straightforward concept, but for sure we can say that brain health is not the same as absence of brain diseases. So when we think about brain health, we are thinking about a very wide range of capabilities and brain structure and functional integrity. And you really want to not reach to the point that the pathologies are very well established, symptoms are there, and then reversal is impossible. So when things get irreversible. And that's the concept that we are talking about. And when we think about that framework, that tells us there's a lot of room for intervention and reducing the risk. So we kind of combine these two concepts of brain aging and aging with the brain health in this publication in Lancet Healthy Longevity. On the x-axis in this graph, you can see this is a timeline for chronological age. We're starting in young adulthood. And the y-axis, we have different brain health trajectories. Basically, starting in young adulthood, we start exposing ourselves to early life risk exposures. That could be changes with the sleep, alcohol consumption, TBI, and so on and so forth. So when our brain would face these life risk exposures or risk factor exposure, a series of mechanisms would start getting activated to compensate for this damage. And what would happen is that when there's this balance between healing and risk exposure, people can go to different trajectories. A compensated trajectory would be that you can handle this risk exposure and keep it to the level that we talk about, that you would not reach to that threshold that the brain disease would manifest. And then the other trajectory will be an accelerated process where you pass the threshold for pathologies, and then you would have manifestation of the brain diseases. And of course, this is not necessarily linear. It can be going to waves and bursts, but overall, we appreciate that there are different forces in place. So when we think about this framework, um, we can think about brain health is really driven by three key drivers. A key driver here is a risk factor exposure, as you appreciate. Basically, individuals have different dose, duration, and frequency of risk exposure. As you appreciate here, it's very important to not have that risk factor exposure. But also, there's a concept of resistance. And I think it's very important to know when we talk about resistance. Resistance means that how you would deal with the adversity, and basically is the action of repair and maintenance. But there's the other concept that we frequently hear about and is important when it comes to brain health, and is the resilience. Resilience basically means that the risk exposure happened, damage happened, repair didn't take care of it, but still you have enough of resilience and brain network that we're going to talk about it, that you can still function despite pathologies established. So in that setting, let me show you a real life case. This is a patient that I have seen in my clinic, a 78-year-old gentleman with history of hypertension, high cholesterol, smoking. Basically, patient came to me, was referred by primary care provider because patient had multiple transient ischemic attacks. Um, we got MRI, and MRI, as you can see, shows that there are these periventricular and subcortical white matter disease, and there are actually some lacunar infarcts that are established. But despite all these patients actually living independently, would report that it still takes care of the finances. There's no necessarily focal neurological deficits, but he will report that his gait is fine, although he's much slower in both walking and thinking. So in this case, this patient had life course risk exposure for all sorts of cerebrovascular diseases. And here you can see that actually there's a sign that resistance has been exhausted because basically structural and functional integrity is vulnerable and the pathology is established. But what is happening here is that actually patient has had resilient brain enough that despite all this pathology are functioning. How is possible to maintain health through aging? And as you can imagine, in this setting, there will be three ways that you'll be able to do that. One is altering life course risk exposure. Basically, you will identify risk factors and manage them and monitor them and take care of them. The other thing is actually using and boosting healthy habits and behaviors that will promote brain uh, health through repair mechanisms. We're going to cover that. And then the third thing is about resilience. You would identify those who have more resilient brain, and then you would do early life interventions. Let's go over each of these items one by one. So when we think about this risk exposure, when we think about dose, duration, and frequency of risk exposure, we need to have some frameworks to be able to systematically review these risk exposures for our patients, for ourselves, for our community. And we came up with this ABC of brain health, which really starts with awareness and goes all the way to blood pressure, comorbidities, inactivity, isolation, and insomnia. So it's a really a good framework. I'm hearing from my primary care colleagues they really like it. But this is about what is the disease or risk factor already established. And as you all know, over the last decade, American Heart Association tried to kind of provide some frameworks for looking at the heart health, not heart disease. And they first came up with these simple seven, which none of it is really simple. Basically, this framework of how you can keep your heart healthy. And then they kind of extended the concept to the brain. And now we have Life Essential A. They added the sleep to these items, which is a really great item. Actually, you can score the state of your vascular health, I would say, which can include heart and brain. But then there has been always this criticism whether these framework or frameworks like this are really indicative of what would happen to the brain, because mainly they are driven from like cardiology world, and we know that brain has much more complex physiology, anatomy, and vulnerability. And actually, this has been kind of evaluated by my colleagues at the School of Public Health at University of Minnesota. Through this very nicely done study, the ERIC study, over decades, they looked at whether if you would be able to change these risk factors, whether that has any implication for the degree of brain small vessel disease. So for those who are not familiar, I put this MRI, as you can see, these like a white matter and these like a black holes. They are indicative of white matter disease or microbleeds and lacunar infarcts and a smaller subcortical infarcts, which they all have. 3 decades ago, we thought that they are benign or it happens, but now we know that they are strongly associated with higher risk of future stroke and dementia. And what they showed actually was pretty extraordinary. If you would be able to even take care of one of those factors, just one, you don't have to do that for all, you would be able to significantly reduce risk of these brain small vessel disease and pathologies within the midlife. But you would achieve even further if you would be able to sustain taking care of that single risk factor from midlife to old age, meaning that not only starting middle age is important, but also sustaining into older age. So actually, even just stopping smoking or increasing your level of physical activity has significant implication for your brain health. And then in the next phase of their study, this published in Alzheimer's and Dementia, they showed that actually in the setting of, and they replicated it in other cohorts, that if you would be able to take care of even one of those risk factors, you would not only have less burden of small vessel vascular pathologies, but you can also lower risk of incident dementia in older age. So these two studies are wonderfully done, but there's always this criticism whether these observational studies can be translated to interventions, and there might be bias involved, which I agree with that. But fortunately, over the last decade or so, now we have increasing number of uh, double-blinded clinical trials and randomized clinical trials that they have tested whether if you would be able to provide some sort of multi-domain intervention, usually involving diet, exercise, cognitive training, and vascular risk monitoring, you are able actually to improve your cognitive function. This is a landmark finger study published in Lancet 2015. And the key to that was that they identified older individuals who had some risk factors, so there was a room for intervention. And then there were a couple of negative trials, but in those trials, I think they had very selective approach in terms of patient selection. But then we had these uh, Sprint Mind study that came and showed that you don't have to do all the interventions. If you want to pick one, perhaps you want to pick high blood pressure. And if you will be able to provide this intensive blood pressure control, you can reduce the risk of combined mild cognitive impairment and incidence dementia. And so many other publications came after that that you might be familiar with it. And then the concept has evolved further, and now we have actually more randomized clinical trial, including a smart randomized clinical trial, that they looked whether in individuals who are 70 to 89 years old, and they might have at least two dementia risk factors. It can be a combination of things. It could be vascular risk factors, medications, depression, and social isolation was added to the list. And they actually showed that if you will be able to provide this multi-domain intervention, you can reduce the rate of cognitive decline and your composite cognitive score will be higher. This was a medium-sized study, and all of these really required a lot of interventions and in person. But I really like this Nature Medicine study that was published last year. And what they showed was that actually, if you would be able to apply online multi-domain lifestyle intervention, actually you can preserve and prevent cognitive decline in adult at risk. And as you all know, recently also there's this like a US pointer trial that kind of had the same concept, again, similar to the finger study. And basically they are showing that yes, with more structured multi-domain intervention, you are able to make some changes in the cognitive decline trajectories. So I'm hoping that I covered the first one very well. So we have risk factors, we need to identify them, we need to be systematic with them. Actually, now there is good evidence that if you will be able to take care of risk factors, frequently multiple of them, but in some cases like hypertension, even one of them, you are able to preserve your brain health. But how about boosting your resistance? And as a reminder, resistance is all about repair. And the key word here for boosting resistance is cardiovascular fitness, which is different than not having hypertension or hyperlipidemia or having issues with your heart. It is all about the health of the heart-brain axis, and we're going to talk about that. So this is a very old meta-analysis. They show that if you have a heart failure, you are have like a 62% higher risk of having cognitive dysfunction. And then we started looking at this heart-brain connection beyond just having a heart failure or advanced heart disease. And what we did, we started, well, what if we would just look at the population that doesn't have overt heart disease, and they might have a little bit of decrease in cardiac function. And we looked at this population with cardiac MRI. And what we observed was really extraordinary in the individuals without any dementia or cognitive impairment or heart failure. You see that the higher is the stroke volume in the heart and cardiac output, the more you have brain tissue. And specifically, you would have more gray matter volume. And this was really persistent over adjusting for many potential confounding factors. We said that, okay, this was just like a cardiac MRI. We cannot put everyone through the cardiac MRI. What if you would have a cardiac biomarker and we look at the trajectory of cognitive function? And we looked at the NT-proBNP, which you might be familiar with, which is like a cardiac marker that we use it for sometimes inpatient or outpatient to monitor cardiac function and heart failure for individuals. But then we looked at those again who did not have heart failure, and what we observed was that even a slight increase in your NT-proBNP as a marker of a cardiac stress is associated with a steeper cognitive decline in this population. They were like 85 years and older, but fairly healthy. And then we thought that, okay, maybe we should just go one decade earlier and in the setting of Prosper study, we looked at the same association, but we looked at specific cognitive domains. We looked at executive function, processing speed, and we were observing really the same thing that um, even without having a heart disease and heart failure, these cardiac markers can really predict your cognitive function, not now, not just now, but also down the road and years. And it was really the case for multiple cognitive domains, for memory function, for executive function, processing speed, and so on and so forth. They were like about a decade younger, 75 years. And then we thought, okay, maybe this is like an older age and everything kind of comes together and then it might be confounded. And then we went even 2 decades earlier and we tested the same hypothesis in the setting of cardiac study in individuals who are in their really middle age, average age of 50 years. And as you can see in this graph, basically these slight increase in your NT-proBNP, that cardiac stress marker, is associated with brain atrophy, specifically in the temporal lobe, more than frontal lobe. These are the key structures for memory function and preservation of cognitive function through the years. So basically, what we are saying, if your heart is under stress, you don't have to have the heart disease. It is not for good for your brain. But what if we would look beyond the heart? Because after the heart, we have the heart-brain axis, meaning that all the vessels that will bring the blood and oxygen and nutrients to the brain. And we tested whether if you would have combination of this elevated NT-proBNP and carotid disease, you might be worse off. And that was actually really the case. So if you have both stress heart and carotid, some degree of carotid disease, you have accelerated decline in your total brain volume and gray matter volume through the years. And it was very prominent to see that, again, gray matter volume was mainly affected. And then in the last part of our effort to look at the whole heart-brain axis, all the way from the heart to the vessels getting to the brain, we did a series of studies, but this is something that we pay attention less to that because I think the whole word of prevention is mainly around heart and cardiology field has been really strong in that area, which kind of overshadowed looking at other places like including the brain. Like these days, we look at CAC, cardiac calcium score, etc. But actually, what we looked at is we looked at the same thing, but also in the brain and the degree of atherosclerosis within the brain vessels. This is really a very common phenomena. About 29 to 37% of population in the United States, depending on race and ethnicity, they have these pathologies. And what we observed was that, again, you don't have to have a stroke, but when you have this uh, brain vessel disease established in your brain, you are at about 2 times higher risk of having cognitive impairment and dementia. It doesn't matter, it was both in observational and postmortem studies. And just to give you a context, this is an increased risk comparable to having ApoE4 genotype, which we frequently talk about as a genetic risk factor for Alzheimer's disease. So now we're talking about boosting resistance. And as I just showed you, that it's so important to not only think about um, not having the risk factors, but also boosting the function of the heart-brain axis as a gateway. And you need to have some primordial prevention. That means really exercise, diet, and sleep to really boost the repair capacity in your brain and in your heart and the heart-brain axis to be able to stay in the trajectory that you can still handle some risk factors and exposures through the life and stay in a brain health trajectory. But as we discussed, there were three forces: risk factors, resistance, and resilience. How can we boost resilience? Resilience is a very complex concept. The best analogy that I have heard is that think about resilience in the brain as a network in the brain, a network that is really taking care of all the cognitive and high level activities that we do. And the more robust and redundant is the network, the less likely you would have trouble with your cognitive function and decline in your functional status. So what would happen is that we are born with this network and we can really enrich this network early in life. And then you would have these like adverse life events which would be hits to that network. And finally the network would hold up, but then finally would kind of collapse. So this brain network function is really what would determine what's your resilience. But how can we boost this network and resilience? And this is through multiple interventions. The very first thing that I think is really important is just where you would start with. And that's why maternal health and fetal health are so important that we need to pay more attention to that as a nation. That would really determine where you're standing, where you're starting your trajectory of brain health. And then through the years, you need to kind of find the ways to decrease these adverse life events, especially during young childhood and all the way to early adulthood. And that way you can really boost your resilience. And when you get to the older age, you have more resilient brain to tackle the pathologies and also function despite those pathologies. We published this concept, and basically, this is what we are going to have if you would really work on boosting resilience early on versus decrease resilience. And as you appreciate, it's so important to pay attention to young age and minimizing the clinical and subclinical damage and really enrich a childhood living environment and good vascular health are key to boost these resilience for the whole life course. And as you can appreciate, when we are thinking about that, we are really thinking about a life course situation where you would start with preventing the brain to get hit from early life experiences all the way to advancing your cognitive reserve through young adulthood and education, prenatal health screening, and all the way you would be in a point that hopefully in the near future we will be able to kind of say that we are dealing with more resilient brain and less resilient brain, and then we can do research stratification and provide customized care for individuals. So with these contexts, I think it's important to take a pause and think about, we know all this is so important, but how are we doing in terms of brain health and adverse brain health outcomes, meaning prevalence and incidence of brain diseases. This is like some data from global burden of disease. What we are seeing is that except some meningitis and encephalitis, some infections, we have increasing number of individuals and mortality and disability from that, from neurological conditions. Basically, what we are seeing is that although we might see that conditions like a stroke have declined in terms of mortality and severity, but these individuals will live longer with us. And you will realize that these data is reflected in this graph and this publication that I'm sure many of you have seen, that as of now, number one leading cause of disease burden in the worldwide is not cancer, is not heart disease, is actually neurological conditions. And stroke, dementia, and migraine altogether form the largest burdensome disease in the whole world, that they can easily bankrupt countries, they can easily affect the well-being of individuals. And it's something that we see that is really a consistent pattern to that. And we are seeing that actually it might get worse because we are living with disability for a longer period of time. So with this concept and with this background, what we are seeing is that we need to have a more proactive approach, meaning that we should not have just the diseases to happen and then think about okay, how to take care of it. And that's really has been really our practice in the whole field of neurology and medicine, that, okay, a stroke happens, we will jump on it, we will take care of the patients. We have made great progress, but this is probably not enough, and we need to have a proactive approach. And it's possible for all the reasons that I mentioned, but also one key feature to many neurological conditions is that they have like a very slow trajectories, and those slow trajectories help us to identify high-risk individuals and implement primary interventions. And in that setting, this is the field that I'm specifically very interested on. And we talk about it as a preventive neurology and at the American Academy of Neurology and a number of other colleagues. We are working on that. In the Twin Cities, in Minneapolis, we have for the first time, we have the preventive neurology clinic where high-risk individuals, before a disease happens, they come to us and we provide care for them. And I'm so happy to see that this has been a brain health initiative in so many organizations that you are all aware of that. So, and then it's also important to not lose this concept that, of course, we will provide care for our individual patients, but also we need to think about population. This is probably, this publication is old and gold. One of the most impactful publications in public health and all field. The title is Sick Individuals and Sick Population. Basically, it says that if you look at the risk distribution in a country, or in every given community. So you have this like a bell shape that there are some very high risk individuals and some low risk individuals. But what you are supposed to do is to shift this risk from very high risk to low risk. But also you have the duty to really shift the whole graph to the lower level of overall public health impacts. And let me tell you, give you an example. So this is a graph now this is a model for a stroke. So this is a risk distribution in the whole population. And it says that if you will be able to take care of those who are in that tail of very high risk individuals for having a stroke, you're able to reduce risk of a stroke for 11%. It's a really huge number. Every year we have 500,000 people affected by a stroke in the United States alone, and you can imagine it's a huge number. But if you would be able to change the population level risk factors for a stroke, you might be able to achieve to 50% of reducing the risk of a stroke. But what if you do the combination? And that's where you get to 90%. Of course, we were not going to get to 90%, but this is important that every activity that we do as an individual level, we should really be advocates for population level interventions in all the communities that we are living at. So how would future look like? I think it's important to keep in mind that when we think about this setting, we think about brain health in a population level, we would remind ourselves that probably we are living in a wide range of high-risk individuals. Very high-risk individuals are always in this tail, and this is what we do all the time, a high-risk approach impact. We would take care of the people who have diseases, and this is something that I do all the time in my clinic. We have individuals who have transient ischemic attack, intracranial atherosclerosis disease. They have other health conditions like coronary artery disease or chronic kidney disease. And then we would have a bit lower risk population. Then we need to also think about them too, because you really want to change this distribution of the risk for the whole population. And that's where the health policy and social drivers of health are important. I practice and work in downtown Minneapolis, and we provide care for very, very wide range of patients with all the social drivers of health. And we appreciate that how much education, how much health literacy, how much resources, like a basic resources like food insecurity, transportation, housing, they are all impacting well-being of the not only individuals but also the whole community. So it's really important to think about it from the lens of the population and think about beyond individuals and an impact that we can make, all of us we can make. So other frameworks to work on that. And I'm sure many of you are familiar with this Lancet Commission 14 risk factors framework. And basically, what they are saying is that a condition like dementia, most common forms of Alzheimer's disease. 2 decades ago, we were talking about the dead end condition. There's no way that you can do anything about that. But now we are thinking about prevention. We are thinking about reducing the risk, and we have data to support that. And there are items that we can go over it. So there are these like a 14 factors. And as you can see, it's really uh, life course situation that we can say that up to 45%, maybe half of those individuals are can be prevented from developing dementia. Something that we frequently miss is that, and again, as a vascular neurologist and preventive neurologist, I always say that the same risk factors are also, at least 10 of them, can lead to 80% stroke risk reduction. So when we think about dementia prevention, we also need to think about stroke prevention, and they are so intertwined with each other. It will be really one stone and multiple birds. But this number, I think, has kind of caused some questions that whether in all individuals, in all the communities, you can have really 45% dementia risk reduction. Obviously, we are not seeing it in many communities. And the reason is that probably we are not focusing in the right population. This is so important to think about that. And I know that this audience are mainly working with the aging population and older individuals. But really, prevention and the highest impact for prevention starts in middle age and young adulthood. In that framework for like life course risk reduction, as you can see, actually the biggest cluster of risk factors are in midlife. And in this very interesting paper, they really highlight that the really impactful intervention should start in middle age. It's a really tricky age group because individuals are busy with their life, individuals are busy with raising kids, and it's so easy to forget about and career, etc. So it's so easy to forget about all these risk factors that will really determine your brain health so early on. So my ask is that always think about middle age as a golden window to initiate the process. And of course, it's never late. And also we need to think about biological age of individuals rather than just chronological age. But the earlier we start, the better the outcome will be. And one other factor that I wanted to kind of highlight here is that, and we are seeing it, that when we think about dementia, we always think about old age, older individuals. But actually, there's this alarming sound that early onset dementia is increasing globally and in the United States. And this is so important to keep in mind that early onset dementia we used to think about these are like genetic causes, but now there's this paper I put the QR code there if you're interested. Is very impactful. Again, a great number of my colleagues at the School of Public Health at University of Minnesota were involved in this very interesting study that showed that same risk factors, even with more some profoundly more impact for late onset dementia, also important for early onset dementia. Inactivity and smoking are probably most important risk factors for early onset dementia. So it's when we have a patient who is in 50s or early 60s and would have like full-blown dementia, we should not think about, okay, this is just a genetic condition. No, actually, less than 5% are genetic conditions. These are all environmental factors and modifiable risk factors to put it at. And last but not least, I wanted to show you this very interesting study published in Lancet Global Health that they say that these 14 risk factors framework, it might be very, very different from one state to the other, one country to the other. And I should say that these 14 risk factor distribution data are mainly driven by North America, Europe, and countries like China with higher socioeconomic condition, and that's where the data coming from. But they did very interesting analysis. They said that if you apply these concepts to countries like Latin America, actually you are able to prevent more cases. So potentially more modifiable risk factors and more impact. And this is really obvious in our microenvironments. Um, we all work in different settings, and you can see that, for example, rural health, rural brain health is very important, and probably what we can do is even more impactful. There are some neighborhoods that they really need attention within our communities, within our counties. So it's always important to not lose the sight that there are all these disparities that can really affect brain health. And wherever the disparities exist, it is a challenge, but also it's an opportunity to implement interventions the earlier the better. I'm going to wrap it up, and hopefully we'll have some questions and discussions. I'm hoping this talk kind of brought up some ideas about brain health and the key drivers for brain health, including risk exposure, resistance, and resilience. I think it helps us to kind of have a framework for intervention. It's so important to think about midlife and also changes in cardiovascular health that can be translated through the whole life course. Think about the whole heart-brain axis when it comes to brain health. It's not just the heart, it's not just the brain, but the whole heart-brain axis. And it's so important to have at least life course perspective when it comes to aging and brain health. It starts really from young age and goes all the way to the old age. I always say it's never too early, it's never too late. And then we also need to think about high risk population. That's what we do in the clinical work, but we need to also think about average population and a population as a whole for interventions. And also, of course, uh, as I mentioned, middle-aged individuals and those who are dealing with social drivers of health are should be prime targets for promoting brain health. I wanted to thank you all my collaborators at different institutions. Um, at my lab, we are working on cerebrovascular care, but also brain health, really from different lenses, especially lens of social drivers of health. And we started a movement and campaign within our institute that really brain health starts with us. And I'm so happy that you are taking lead in this area and thinking about that, because it's so important to educate our own colleagues, our own community, ourselves, that we need to have interventions early on. We need to have infrastructure to implement brain health prevention strategies, but also we need to work on ourselves to educate our patients about that. With that, I'm going to wrap up my talk. And again, thank you so much for the opportunity to be here, and a pleasure to um, join this great symposium.